Our presentation is on boosting stigma-free care for psychiatric patients.
So just to start off with a little bit of background, what is mental health stigma? So stigma is when someone views a person in a negative way solely based on their mental health condition, and this may cause that person to feel feelings of shame or judgment and really deter them from speaking up about their mental health or talking to someone about it. So there are different types of stigma and ways that it presents itself. So the first type is public stigma, which is more of a generalized negative view that society may have towards people with mental illnesses in general. An example of this is people with substance use disorder. A lot of the times they are misjudged or assumed. People think that it was their fault or it's their choice to live that kind of lifestyle when this is simply not true. And people don't really recognize substance use disorder as a mental health condition and don't treat it as such. The second type of stigma is self-stigma, and this is more internalized. This has to do with the person with the mental health condition and their feelings about themselves. And an example of this is people with clinical depression. Many times they don't know why they're having negative thoughts or negative feelings, and they might be really hard on themselves, asking, why am I so depressed? Why do I feel this way? There's nothing that is depressing. And they feel forced or pressured to kind of put a happy face on or present as happy to others to kind of compensate on how they really feel on the inside. The third type of stigma is institutional stigma, and this is more systematic and organized within our healthcare system, within the policies and procedures that may intentionally or unintentionally limit opportunities for people with mental illnesses. An example of this would be how certain healthcare insurances still don't cover therapy or certain mental health treatments because they don't really see mental health as a valid reason or a valid disease. And now Iram's going to talk about how stigma negatively impacts patient care.
All right, and the main point that I want to get across about how stigma negatively impacts patient care is that stigma prevents patients from seeking help. The average time that it takes a person to seek treatment after developing symptoms of a psychiatric disorder is 8 to 10 years. So let that sink in. It's not 8 to 10 days or weeks or even months. People wait 8 to 10 years before they get help. Imagine if someone was throwing up blood every single morning for 10 years before they went to see a provider. No one would do that. So then why do people do that with mental health disorders? It's because of the stigma. And then patients that do seek treatment often feel dehumanized and dismissed by their providers. And a great example to showcase how this happens is when a patient with a psychiatric illness complains of pain. Oftentimes, these patients get told that the pain is in their head and they might not get a full assessment. They just get told, oh, it's in your head, it's not real. And this is a great disservice to the patient, whether or not this is intentional by the provider. So stigma is holding patients back from seeking treatment, and then it's also leading to biased and marginalized care when they do go out and seek treatment. And now Jennifer is going to talk about some examples of trivializing language that further perpetuate the stigma.
Yeah, so we have a couple of examples in the middle of our poster, but just for time's sake, I won't go over all of them, just the ones that we think are kind of prominent today within society and contribute to public stigma. So trivializing language can be terms we encounter every day and we just don't really think about it. So an example would be describing someone who is organized and tidy. Maybe they color code their notes or they like their pens a certain way. Describing this kind of person as OCD or saying, oh, that's so OCD of you. This can be very trivializing to people with clinical obsessive compulsive disorder and really diminish or belittle the seriousness of what people with clinical OCD experience every day, where their compulsions may significantly and negatively impact their daily life. Another prominent one we wanted to address was when someone, or maybe yourself, you're having a bad day, or maybe you spilled your coffee, you're a little upset, and you might say just casually in passing, "Oh, I'm so depressed." But this is not the same thing as clinical depression and can really trivialize how people with clinical depression, what they feel on an everyday basis. So the next time you hear trivializing language, don't hesitate to challenge that person or even yourself and help them use a more respectful alternative to say what they're feeling. And Iram's gonna talk a little bit more about that.
Yep, speaking of respectful alternatives, I'm going to talk about stigmatizing language and what some respectful alternatives are for that. And what we want to promote is the use of person-first language that puts the person before the disorder, describing what a person has and not who a person is. So an example of this is, instead of saying Donna is bipolar, saying Donna has bipolar disorder. Or instead of saying Greg is an alcoholic, saying Greg has alcohol use disorder. And what I thought was kind of a funny example that even sounded weird to me was, if you think about someone that has hypertension, if you said, "Oh, Will is high blood pressure," that just sounds so weird. You wouldn't say that. You would say Will has high blood pressure. And we just want the same thing with mental health conditions. Describe what a person has, not who they are. And instead of referring to someone with words like crazy or nuts, just say that there's someone living with a mental health condition. Don't use those trivializing words like crazy or nuts. We want to promote the use of person-first language. And now Jennifer's going to go over some myths about mental health disorders.
Yes, so now to do some myth busting. The first myth we have is people who live with mental illness are violent. And this is often propagated through the media. A lot of the times we see violent people or people behaving violently, and the public may assume that that person has a mental health condition because they're acting that way, and they will blame their mental illness on, or they'll blame their violence on the mental illness. So this is not true. It's, in fact, people with mental illnesses are no more violent or dangerous than the general population, and they're actually more likely to be victims of violence, especially self-harm. The second myth we have is some cultural groups are more likely than others to experience mental illness, and this is completely false. There's no cultural group that's more prone or immune to mental health problems, and anyone can develop a mental illness. The third myth we have is people with mental illness only experience mental symptoms. Mental symptoms meaning thoughts or hallucinations, things that go on in someone's head, but this is false. Mental illnesses not only present by negatively impacting your mental state, but also your physical state. So oftentimes patients with mental illnesses have physiological symptoms such as insomnia, gain or loss of weight, gain or loss of energy, chest pain, nausea. And this is all the more reason for us as healthcare professionals and students to encourage people with mental illnesses to seek treatment.
All right, and now to wrap up our presentation, I'm going to discuss what the role of a pharmacist is. So the role of a pharmacist is to recognize all of the things that we talked about today, recognize the trivializing language that you see out there, recognize the stigmatizing language that you see out there, and get rid of it. Challenge the misconceptions that you see, challenge the misconceptions that you hear on a daily basis, and advocate for the patient. As pharmacists and pharmacy students, we play a huge role in the community, and we need to display sensitivity and build that patient trust. Pharmacists can play a big role in reducing polypharmacy as well. A lot of patients with psychiatric disorders get more and more drugs added on without considering non-pharmacologic therapies. And we can address this by reviewing a patient's medications, evaluating the adherence, and suggesting non-drug therapy alternatives when possible. I urge you all to strongly consider how stigma plays a role in healthcare and work to eliminate it. Thank you all for your time and attention. What questions do you have?